Tests and signs for the wrist. Hand grip test. To test the function of the wrist joint, the finger flexors and the intrinsic muscles of the hand, the physician asks the patient to grasp his second and third fingers. If the grasp is loose, the test is positive. Tinel's test. The physician taps over the course of the median nerve in the carpal tunnel. Numbness and aching of the lateral 3.5 finger is a positive Tinel sign. Carpal tunnel syndrome might as well be proven by the thenar muscles amyotrophy and reduced or complete loss of function. Fallon's test. The physician asks the patient to hold a wrist flexion for 60 seconds while the elbows are fully flexed. Then, the physician asks him to press the back of both hands together to emphasize the presence of any sign of positive result. This will compress the median nerve. If there are any numbness or tingling before the ending of the 60 seconds, it indicates a positive test. The grind test. This test is done to assess the triangular fibrocartilage. The physician holds the wrist and makes an ulnar deviation, and then he rotates the wrist. Pain or grinding sensation around the ulnar aspect of the wrist might indicate an injury of the triangular fibrocartilage. Watson's test. The physician puts his thumb over the scaphoid tubercle and his fingers over the dorsum of the wrist, then extends the wrist and moves it from ulnar to radial deviation. This test checks the integrity of the scaphoid lunate ligament, so if that movement is painful or if there is a clunk, that may imply an injury to the scaphoid. Stability test. The physician stabilizes the patient's forearm and then moves the patient's hand back and forth in a calm way. It's an inoffensive subluxation. The test is negative if the amount of movement is minute. It can be done as well on the metacarpophalangeal joints to assess any dorsal or palmar instability by stabilizing the metacarpal and moving the proximal phalanx back and forth. Collateral ligaments test. The physician extends the patient's metacarpophalangeal joints, stabilizes the metacarpal bone, and passively moves the patient's fingers medially and laterally. Presence of movement is normal, but when the doctor passively flexes the patient's metacarpophalangeal joints, no similar movement should be allowed. Presence of movement in this position indicates a torn collateral ligament. The similar procedure could be done on the proximal interphalangeal joints and the distal interphalangeal joints to check the collateral ligaments there. Signs. Tuck sign. It is defined as a precise superficial bulge in the extensor surface when the physician asks the patient to extend his wrist. It usually appears when the patient suffers of extensor tenosynovitis, which is the swelling and tenderness of the tenosynovial sheath. This sheath wraps the extensor tendons that insert in the hand. It extends 2.5 centimeters proximally and distally to the extensor retinaculum. Piano key sign. The physician presses down on the ulnar head. A positive result means that the ulnar head is mobile and goes downwards, then upwards as the doctor presses it, similarly to a piano key. This sign indicates disruption of the radio-ulnar ligament, which may be due to a rheumatoid arthritis.